Good afternoon, everyone, and thank you for joining today's Medicaid Managed Care Plan Billing Panel. I'm Caitlin Cronin from the MCTAC, or Managed Care Technical Assistance Center, and we're excited to have you here today for this panel. Before we get started, we're going to go through just a few logistics and housekeeping items. We will be posting the slides and the recording from this webinar after the last of these panels, so you can expect them next week. You can look to them for any of the resources or contacts that are shared during this presentation today. We are planning to have a large amount of time to address your billing questions for the Medicaid Managed Care Plan, so we do ask you to chat them in throughout. You don't have to wait till we get to that section. You can chat them in throughout the webinar. If the chat is not already accessible, you can get it by hovering over the toolbar and clicking the thought bubble, and that will pull up the chat. And you want to be sure to chat to all panelists so everyone can see your chat. As you can also see, we have each of our panelists on camera today. So you can manipulate how you see the camera view by hovering over the top of your screen and clicking layout. We recommend that you look at the grid view, especially when we take the slides down off the screen, because that will allow you to see all of the panelists at once, and it'll feel a little bit more like an in-person session. All right. So with that, I'm going to go through our agenda for today. So we're going to start with a brief tool review, and then, as I said, the majority of this will be the plan panel. Each plan panelist will open by introducing themselves and going through some general billing information and resources, and then we will go through some common questions and answers before we open it up to the Q&A, both the Q&A that you all submitted and via the survey when you registered, and the Q&A that you guys chat in. For the Q&A, we just ask that when you chat things in, if it's about a specific service or program, please let us know which one. And if it's something super nuanced or very particular to your relationship with one plan, then it's probably best to send it to the contact information that you'll see on the screen or to the contact information from the matrix. All right, so before that, we just want to start with a tool review. So there were 3 billing and RCM tools that we released in the summer to help you be best prepared and have these resources easily accessible. You can access them now at any time on the CTAC webpage under the Tools section. There are also direct links to them in this PowerPoint that you'll see once it's posted. So the first one is the top denial reasons tool. So this is a compilation of reasons that you might get a denial on a claim. It has the code, what that code means, how you can work to resolve it, as well as any particular plan nuances for how to resolve it or how to deal with that particular field or code. The next tool is the RCS best practices tool. This goes through various elements that should be part of your day-to-day. It shows when it happens in the process, how you should manage this, and how it might interact with the claims that you're submitting or the denial codes that you're getting. So all of these tools work best if you use them in conjunction with each other. So you can use the denial tool with this revenue cycle management tool. And then the last tool that we released this summer was the best billing and RCM best practices. So this is a one-pager with some tips for working with Medicaid Managed Care Plans to bill. So again, you can have this, you can see on there. It also links to the matrix, which has our contact information for various contacts across billing, credentialing, for each of the Medicaid Managed Care Plans. And we also have our billing tool, which is the interactive UB04 claims form. All right. So those are some of the tools that we released that we just wanted to make sure you saw aware of. And now I'm going to turn it over to Ellie, who is going to begin the presentation of the day. Elliot?
Hi, everyone. This is Elliot from the Fidelis Care Provider Relations Behavioral Health Specialist. So today I will be going over some of the slides for introductions. You can start with the first slide. Yep. Next slide. So we have a couple of resources available on our website, www.fideliscare.org. One that we highly recommend would be the Provider Manual. This is an excellent resource for you to review. specifically Sections 12.1, claim submission, Section 12.2, billing guidelines, Section 21, behavior health, Section 24, healthier life, health and recovery plan, or HARP line of business, and Section 25, Medicaid children expanded benefits. We also have our authorization requirements posted on our website. The authorization grid available there is updated monthly, and you can go into that grid and check your code to see if it requires authorization. We also have various provider tip sheets available on our website. Examples would be the BH billing and coding tip sheets, the BH HCBS tip sheet, and CSTSS. Next slide, please. So I also want to bring up the provider portal online. This is for our participating providers. This allows them to check member eligibility, claim history, online authorizations for inpatient and outpatient behavioral health services. You can obtain remittance advices and other important documentations. You can search for other participating providers, and there's also updates available on the portal. I also included the provider user guide in case you need to troubleshoot an issue. It also teaches you how to submit a authorization and check authorization status. And if you're a new provider, participating provider that needs to register for the portal, we've included the phone number for the provider call center, or you can outreach to me directly and we would get you set up for the portal. Next slide, please. So electronic submission of claims. Submitting claims electronically means you get faster processing and reimbursement of clean claims, reduction and or elimination of the number of claims not being received, proof of timely submission through electronic acceptance reports. Fidelis Care's preferred clearinghouse for electronic claim submission is Fidelis. You can enroll by calling Fidelis Client Services. Claims can also be submitted through the clearinghouse Ability. Fidelis Care offers free online claim submission through Ability's claims portal. And if you want to learn more about Ability, you can give them a call as well. You also have the option to contact another clearinghouse to initiate 837 claim submission to Fidelis Care. Just need to confirm with the clearinghouse that they will be forwarding the claims to Fidelis Care on your behalf, and they will set up the application process for it. Next slide, please. This slide has a few BH contact information that we feel that would be useful. The BHQ for clinicals or any of those things, you can call them with the extension, their email, the HARP queue as well, Children's Medicaid queue, and there's some BH phone extensions for mainstream, HARP, Children's Medicaid, Medicare, crisis, health homes, HARP enrollment. So if you have any kind of problems in those fields, you can give them a call and a care manager should be able to assist you with those issues. That's it for Fidelis.
Thank you, Elliot. And now I'll hand it over to Cheryl from Beacon.
Thank you very much. Good afternoon, everyone, and thank you so much for joining this call. My name is Cheryl Foley. I'm the Director of Provider Relations at Beacon Health Options for New York. I'm sure either myself or a member of my team has had the pleasure of speaking with many of you over the course of the past year or so. So welcome. I'm very happy that you could all attend. Beacon Health Options, as you may know, is a behavioral health company who works with the plans to administer behavioral health benefits. And for the purposes of this meeting, it is the behavioral health benefits for the Medicaid population. On this slide, you're seeing our New York map, which just shows a quick overview of where each of the Medicaid plans we work with are located and where their Medicaid populations reside. On the next slide. This is a resource for your use when submitting claims to Beacon. This can be shared with your billing teams, your clearinghouses, and your revenue cycle management teams. For each of the plans that we work with, we have listed out different means by which you can submit claims. Across the columns, you'll see each of the options for submitting claims. If you submit through one of our portals, the information is listed depending on the plan. There is also information on whether you can submit individual claims or batch claims. And we've also included our payer ID, depending on the plan, as well as the claims mailing address for paper claims. Again, you can keep this as a resource to share with your billing teams and your revenue cycle teams. On the next slide, this is simply a screenshot of the front page of our website at beaconhealthoptions.com. There are many resources available to you on our website. You can go into our portals from this page, which allows you to review eligibility, submit claims, etc. It also has guidance on how to become a provider with Beacon, as well as other features such as the ability to review the provider handbook, and also reviewing specific plan information, and also how to contact Beacon depending on your questions. When you access our website, you'll also see the red banner there where providers can click on for the latest information regarding COVID updates, which includes information on state billing guidelines, cost share waivers, etc. There is a lot of New York state specific information on this site, and we certainly invite you to review that information at your convenience. And then on our final slide, this is also a resource for your use, which includes our National Provider Service Line phone number, which is available to you anytime from 8 a.m. to 8 p.m. Monday through Friday. That's it for Beacon. Again, I want to thank you very much for attending.
Thank you, Cheryl. And now I'll turn it over to Fidelis and Kalina.
Hi, good afternoon. My name is Kalina Colon, and I'm the Director for Behavioral Health Network at HealthFirst. I want to thank everyone for hosting this panel this afternoon and for being able to share this information. Next slide, please. So first, I'm going to go over some of the high-level billing requirements. So for our OMH and OASIS providers, the claims must be submitted on a UBO4 form. We, like other plans here today, recommend that you submit your claims electronically. That leads to faster claims processing, enhanced overall AR processes. We also ask that providers always refer to the applicable billing guidelines when submitting claims to ensure that you have the appropriate rate codes, CPT codes, and modifiers, and the combinations thereof for the particular services that you're billing for. Claims must include a number of items. MCTAC has done a great job with their billing tool, which they went through earlier, which lays it out plan by plan. And we recommend also that you go take a look at that because it's all laid out for you. Next slide. I quickly want to go over the claims appeals process. I think this is a frequently asked area of consideration of how do we engage in the R&R and claims appeals process. For HealthFirst, appeals are within 90 days. They can be done through the provider portal or in writing, and second level appeals are within 60 days. Next slide, please. Most importantly are the provider resources available to all of you to help you along the way. We have our provider resources page on our HealthFirst website. On this page, you will find provider alerts, COVID-19 updates, authorization guidelines, frequently asked questions, tips and tricks, and so on. And there are so many resources for all of you. If you need help navigating the resources, we're happy to do that for you as well. Similarly, we have access to our provider portal, a secure provider portal for all of you. On the provider portal, you can look up eligibility, you can review your claims, you can manage your authorization requests. So you can request authorizations and view authorizations as well. And as stated earlier, you can also do your appeals through the provider portal. There are other features to the portal. If you would like a training on the provider portal, we are also happy to do that. All the providers have dedicated account managers. This was something that HealthFirst started in 2015. Dedicated account managers offer initial orientation to new providers. We assist with credentialing overview, as well as contracting and technical assistance. Next slide. If you need help accessing your account manager, you can reach out to Maurice White, team lead, and he can direct you to your personal account manager. And in the next slide, we've laid out all the account managers with the various territories. Obviously, some agencies cross territories, so it would be just the one account manager, but if you need help making that connection, we are happy to do that. We also do all of the trainings for the providers and the technical assistants, so happy to do that. And that's it for HealthFirst.
Thank you, Kalina. And now I will turn it over to Heidi from United.
Hi, good afternoon, everyone. My name is Heidi Hopkins. I'm a New York Network Liaison for United, and I'm here to tell you a little bit about our plan. Next slide, please. First, let's talk about claims submission. So if you're going to submit your claims electronically, which is highly recommended, our payer ID is 87726. However, if you have to submit your claim via paper, down here you want to make sure you're submitting it on a UBO4 claim form, but no photocopy, so it has to be an original. Make sure your information is legible, and then complete all the required fields. And you're going to want to mail your paper claims to the P.O. Box there in Salt Lake City, Utah. Next slide, please. So you're going to want to make sure that on your claim form, you clearly have your agency or facility information. Also want to make sure you have the correct member information, the name, their Medicaid ID number, and their date of birth. Also, you want to make sure you include your tax ID number, your NPI, and your taxonomy code. Make sure those ICD-10 codes are on there, as well as your value codes, rate codes, your revenue codes, CPT, HCPCS codes. You want to make sure that you're putting those all in there and make sure they're all matching, so they're telling us what the correct service is. Make sure you have the correct date of service as well. Next slide, please. And here's a few quick reminders. Make sure you're always verifying member eligibility prior to rendering those services. Services that require authorization, you want to make sure you're getting that authorization before rendering the service. Make sure you're using that 24 value code in the UBO4 form. And remember, there's only one rate code allowed per claim. Make sure you're including any of the modifiers that go with your CPT or HCPCS codes. When you're submitting your claim electronically, please make sure that when you put your tax ID number in, there's not a hyphen in there. Also, as stated before, the MPI numbers are required, the complete diagnostic code as well. And please make sure to review your provider remittance advice regularly to identify issues early. Next slide, please. So we're going to talk about appeals for a second, right? So sometimes, the claim doesn't turn out the way that you wanted it to, and you need to appeal your claim. So our appeals should be submitted within 60 days of receiving your provider remittance advice, and you would send it to the P.O. Box listed below at the Salt Lake City, Utah address. Next slide, please. This is our authorization system. So we have a system called PAN, which is Prior Authorization and Notification. It's an online system where you can submit your authorizations online. We do offer trainings on this system. So if you are interested, please reach out. If you haven't had training on this system and you're unsure how to use it, I can get you set up with the trainer and get you some training on this system. Also, if you're not able to do it online, we do have a telephone number you can call to get your authorization. Next slide, please. Here you see some of our online resources. Our uhcprovider.com will help you with checking that member eligibility. You can check on your claim status and payments. You can submit claims reconsiderations, and you can look up EDI information. There's also other tools and resources available on here as well. ProviderExpress.com, I would say this is one of the most used sites. We do have a copy of, the children's under 21 manual there. We have the adult manual there. We also have our network manual there. We have information on that PAN system there. We do have any COVID updates listed out there, and there's trainings that are available on that site, as well as, we can offer the online training as well. The uhccommunityplan.com, there's a lot of updates, that are regarding the state updates and whatnot on that site. And then Live and Work Well is really our provider search engine site. Next slide, please. And finally, this slide has your contact information for who you'd reach out to as your network manager in your area. As you'll see, we kind of break it out by different counties and areas and what type of provider you are. Most of you will probably be reaching out to, well, I guess all of them here, you're all within those areas. But if you have any other questions, you can absolutely send it to that New York Network Management mailbox at the bottom there. And that's all for me. Thank you.
Thank you, Heidi. And now I will turn it over to Boris from MCTAC, who is going to be moderating the Q&A period of our panel.
Excellent. Thank you, Caitlin, and all of our panelists. So my name is Boris Vilgoran. I'm the Healthcare Innovation Officer here at MCTAC. And really, we want to spend the rest of today's presentation going over some of the questions, some of the common questions that we get and the plans get. We also want to say thank you to those folks who submitted questions ahead of the time as part of our survey. So we want to get to those questions as well. And then, of course, open it up to questions from our attendees. So again, just as a quick reminder, we are recording this. The slides will be made available as well, both the recording and the slides. This is our second region that we're doing this. We completed one earlier this week and doing another one next week. So both the recordings and the slides will be available after we complete our third presentation. So please be on the lookout for that. And again, want to encourage folks to continue submitting questions through our chat. I know we already got a number of them in, so I appreciate that. So please do that, because we really did mean for this to be more of a way for you to talk to the plans that are here today to present and answer your questions. So with that, we'll start with our first round of questions. Again, some of the common questions, moving on to the next set. So with the first question being really starting with, what are some of the, denials that you predominantly see from the plan's perspective, right? The common denial reasons you are seeing, and how can this be addressed? So that's our first question. And maybe we'll start with Kalina.
Hi, thank you, Boris.
Yeah.
So some of the most common denial reasons that we encounter with providers are no authorization denials, as well as duplicate claim denials and eligibility. So I'll talk a little bit about each of those. So with the no authorization denial trend, I would say that's probably the most common currently. And really, providers should ensure that if there is a notification or authorization requirement associated with a particular service, that they are submitting those requests to HealthFirst through either the provider portal or through the various email and fax lines available. If they need help with training on that, we're happy to assist. So that's number one. So ensuring that you have a valid authorization prior to submitting the claim is key there. So with the duplicate claim denials, we see that in a number of scenarios. One of the common scenarios that we encounter that with is providers are actually trying to submit corrected claims, but they continuously sending in sort of like the new claim. So the outcome on the original claim maybe didn't end in payment, so they didn't get paid. And so attempting to resubmit that for payment. If a provider is trying to submit a corrected claim, should follow the corrected claim process. There is a one-pager on the HealthFirst provider resources page, which sort of walks you through how to do that. I would say that's probably the most common reason for duplicate claim denials that we've encountered. And then really with the eligibility, we've all said it, check eligibility prior to rendering services. That's really key. And then with the children's HCBS, you have to ensure that they have the K code. And that's just a nuance in the process that we just sort of have to be aware of.
Excellent. Thank you for that. So let's move on. Elliot, let's move on to Fidelis next.
Thank you, Bruce. So the most common denials that we see here at Fidelis is the timely filing denial. So I wanted to make sure that you're aware that for Fidelis policy, timely filing is 90 days from the date of service. So you want to make sure that you're billing your claims within that 90-day gap. Also, corrected claims are 60 days from the remittance advice decision. So you should, if you want to change your claims, you want to make sure that you want to do that within 60 days of that. Make sure that when you're billing electronically that you're including the original claim number as well as having the claim frequency type code as a 7. That demonstrates that it is a replacement of the original claim. We also see a lot of EDI rejections. These are rejections from the clearinghouse. And that happens usually when it's not billed with the proper information. We send out rejection letters within 2 business days, and that clearly tells you what information is missing, if there's a missing box, and we highly recommend that you submit it with the correct information so that you can avoid those rejections. We also see a few provider billing errors happening. Typically, it's invalid rate and procedure code combinations or rate code inconsistent with units. So you need to double check with the state guidances and make sure that you are billing with the proper procedure code and the rate code that they are together. We have a couple of billing guidelines on our website, so you can check with that as well. But the claims need to be clean in order to be received. That's it for me.
Excellent. Thank you for that, Elliot. I think we'll move next to Heidi at United.
Sure, thanks. So for our denials, I have to say we see much of the same as my last 2 colleagues spoke about. We do see that eligibility denial quite a bit. So that's one of the reminders, make sure you're checking that eligibility, as well as that no authorization. And usually it is for the services that, didn't get the authorization before they were rendered. Or sometimes we see that no authorization if we have an out-of-network provider submit a claim, our claims will deny for no authorization. So if you call and get an authorization, that claim will pay. And then we do see a lot for the billing and the coding denials, mainly for a lot of the children's services, since a lot of the CPT and HCPC codes used for billing are the same, but the rate codes and modifiers are kind of what drive the difference in the service. So just make sure you're paying close attention to what rate codes and modifiers you're putting on that claim. But that's the top 3 denials I would say we see.
Excellent. Thank you. And Cheryl?
Thank you, Boris. So for Beacon, the most common denial reasons that we're seeing, first is no authorization for diversionary services denials, where the number of visits approved or the time frame on a previous approval has expired. So please ensure that authorizations are on file or extended prior to billing for your services. Also, we see non-covered services. This is commonly due to a provider billing error with regard to modifiers. So please note that telehealth modifiers are required for telehealth services and are used in addition to the base modifier. So for example, if you're billing a pro service that has a base code of H2019 and a modifier of U2, you still have to use that U2 modifier on that procedure code along with the GT modifier when you're billing it as a telehealth service. So please don't leave off that U2 modifier and bill it as just H2019 GT, because H2019 by itself is not a covered benefit. So be sure to visit our website to review and register for any number of our provider-focused training webinars that can help you with both of those types of denials.
Excellent. Thank you, Cheryl. So I think our next question, and I think all of you touched upon it, is really about authorization, right? Authorization is definitely one of those areas. I think I'm getting a little feedback, so if folks can just mute themselves. Um, Thank you. So just wanted to see if there's any additional pieces around authorization and especially around notification, maybe we can touch more a little bit on, because there are some services that might not require authorization or the authorization kicks in later. So I know, again, you guys touched it, so I don't want to go over it again, but just want to see if there's anything else around authorization or notification you want to talk to Cheryl. We'll go back to you, actually.
Sure, thank you. So what we have found that's most important to remember regarding notification versus authorization is to really know which services require the notification of admission, such as inpatient services for substance use, mental health, and how many days you get approval, automatic approvals for, whether it's children, adults, etc. And then which other services may require authorization as opposed to a notification of admission. So an authorization would be required for things such as diversionary services. And again, one of my most important things as a provider advocate is to please make sure that these are on file prior to submitting claims. And again, all the assistance that you could require for training is available just by registering for our webinars on our website. Thank you.
Excellent, thank you. Let's go to Helena right now.
Hi.
Hi.
So, really what's key here with authorizations and notifications, number one is knowing which services require authorization and or notification. And we can always guide folks on that if they have questions. They can always call in as well. And when it comes to the various forms that are required. So obviously with the CFTSS, there's a form. With the Children's HCBS, there's a form. CFTSS, it's an actual, with HealthFirst, there is an authorization requirement on 2 of the services. So you have to ensure that you get that form in prior to the 4th visit. With the Children's HCBS, currently it's a notification, but we still expect that form. So those forms can be faxed over to us. If you're having challenges with the workflow and processes, we're always happy to engage in a training around that, one-on-one, tailored to your organization. And similar to what was said earlier, certain services like inpatient, you should just, call us to let us know, but there are regulations that apply. So, and we obviously would adhere to all of that. And really, when you're reconciling your authorizations and trying to make sure, did my organization get an authorization prior to submitting a claim, you can always check the provider portal to determine if that's on file, and you should always ensure that where applicable, that authorization is on file prior to submitting the claim. Otherwise, the claim would deny. So that's basically a quick overview on authorizations from HealthFirst.
Excellent, thank you. Elliot, on your end, in regards to authorization and notification?
Yeah, so it's very important for authorizations that you are billing with, you are confirming the correct NPI, the tax ID, service location, and the BH service and the service type. And you have to make sure that what you are billing on the claim is identical to what authorization you're receiving. Most of our outpatient behavioral health services do not need auth, but you can always check with the auth grid that I presented earlier to check the code, because there's always exceptions. Oftentimes, when an auth is asked for, if you are out of network provider, make sure that you're stating that, because out of network providers need a single case agreement to go over the rates and all of that, and it won't be able to progress if you don't let them know. You can always email or fax required documentation to the inboxes that I had presented earlier. That way, we have all the information we need in case we need to do a medical necessity or any of that stuff. Yeah, that's it.
Excellent. Thank you. And Heidi?
Sure. I would like to echo much of what my colleagues just stated. Definitely make sure you're checking our Provider Express site, as well as you can reach out to your network manager to see what services do require an authorization versus the notification. And, just like Elliot had just said, we do also require that single case agreement for out-of-network, so make sure you're reaching out to get that prior to rendering the services. And I think one of the most important things I can tell you is that make sure that what you're getting the authorization for matches what you're billing for, because sometimes we'll see, it won't be the proper dates or the right service or something, and that's why your claim will deny. So making sure it matches is a very, very important piece. Thank you.
Excellent. Great, thank you. And the third question that we commonly get as well, and I know you guys actually in your PowerPoints addressed it, and again, just want to let folks know that you'll have the access to this PowerPoints and the links and everything, was around appeals, right? So the appeal process. So we wanted to, see, if there's any additional things the plans want to talk about in regards to their appeals process. So I think with this third question, I'll start with maybe Elliot around Fidelis.
Yeah, so I'll go over briefly the appeal process that we have. So just like the corrected claims, you have 60 days from a denial or overpayment, underpayment, whatever you're contesting, to fill out a claims appeal form. That is located on our provider manual at section 13A. It has all the relevant information there, the claim number, the reason for denial, and also the address. And we do expect you to mail these appeals in. I highly recommend you put it in through certified so that you can track it. But yeah, you want to include with that appeal whatever rationale you have for appealing, and make sure to be as specific as possible. But appeals must be in paper, and it must be filled out with the form attached and mailed.
Excellent, thank you. Heidi, I think we'll go next to you.
Sure. So same with United, it is 60 days from the receipt of the provider remittance advice to submit that appeal, and we do accept those appeals via mail. You can find more in-depth information in our provider manual about appeals, but you do want to make sure you're including all of that documentation that you want reviewed within that appeal, and get that sent in the mail. And again, probably certified mail would be a good idea too.
Excellent, thank you. Now we'll move on to Cheryl.
Sure. For the New York Medicaid plans, we would ask you to please submit the member's medical record along with a cover letter advising the exact services and dates of service that you are appealing. You must submit the appeal request within 60 calendar days of the initial adverse determination. And as long as all requested information is received, the Beacon Review provider will render a decision, and a letter is sent to both the member and the provider within 30 calendar days of receipt of all information for that appeal. There's one level of internal appeal, and if that appeal is upheld, the determination letter will include information on how to submit an external appeal and the time frame for doing so.
Excellent, thank you. And now, Kalia.
So for HealthFirst, the review and reconsideration first appeal is 90 days from the date of the remittance. Similarly, you can mail in the appeal with all the corresponding documentation, and that information was on the slides, as well as you can submit an appeal through a first level appeal through our provider portal. That's a sort of a newer functionality that is available to providers. So that's for your first level appeal. If you don't get the outcome that you expected with your first level, you will be able to do your second level appeal. For second level appeal, you have to mail it in, and that's 60 days from the date on the letter that you received regarding the outcome of your first level appeal. And all of those particular details, again, are on the slides. If you're having an issue that's not just the onesie twosie claim issue, so you see something sudden that's impacting many claims, we suggest you reach out to your account manager so we could handle that separately and apart. But generally speaking, most claims would need to go to the appeal process, and your account manager would direct you as such.
Excellent. Thank you. So that kind of concludes some, the common questions. So we really want to pivot now to the questions we've been receiving, and I want to thank all the attendees because we've been getting quite a few questions through our chat. So thank you. We'll try to get to as many questions as possible today, but we will be sharing all of these questions with our panelists. So they, can also potentially reach out to you, or please, as you get the contact information, feel free to reach out to the contact that's listed on the PowerPoint presentation when you get them. I also want to just highlight, when I kind of was looking and listening to the presentations by the plan, and also knowing what we have at MICTAC, there's a lot of resources out there. And sometimes folks might not be even aware what's available, both on the plan side and even with MICTAC. And so I definitely want to encourage folks to use the resources and sign up for notifications and all the portals that I think are available. The other common theme, and I know folks who are today are listening in are tired of me saying this, but I think I can't say enough about communication between providers and plans, and how crucial it is that folks reach out, especially when they're running into problems, and talk to the plans. And the key here is always timing is important. The sooner I think providers find out there's an issue, either it's your own internal issue within the provider, or it potentially could be an issue with a plan. Either way, I think it's good to reach out as soon as possible and not wait, because then it just kind of grows into this large, many claims, many issues. So that has been always my kind of soapbox a little bit, and saying, hey, just reach out and talk to folks. And hopefully with today's presentation and with additional information on who to reach out, that would be helpful. So I know one of the questions we got in the chat is in regards to claim submission and how often claims could be submitted. So just I'm not aware of, there's a limit if you can do it daily or weekly or monthly, but I just want to make sure you guys have an opportunity to say if there is any limitations on how often, claims could be submitted into your plans.
So for United, we don't have any limitations as to how often you can submit claims.
Same for HealthFirst.
Same for Beacon.
Yeah, there's no limitation on Fidelis then.
Excellent, thank you. That's what I thought, but I just wanted to make sure. I know that was one of the questions we definitely got in. There's also always the NPI questions, almost always, the one that comes up. A lot of, tends to be confusion about NPI, especially around referring providers. NPI, all, different programs have different rules in regards to when you put in and what you put in the referring provider. It's a little detailed and technical. And so I don't know if folks can address it. I know we in our billing form work closely with you guys in general to indicate what should go into that field. Because for sometimes you can, for example, if my memory serves me right, you can use actually the agency NPI for some programs. Sometimes you actually have to put an individual's NPI, and so there's different rules. So I don't know if anybody has any additional information or any, because I also know some of your colleagues have are joined too, if they would need to answer or provide any additional information about, especially referring provider NPI.
This is Cheryl Foley from Beacon. For our claim submission, regardless of whether it's a HCFA 1500 or UB04, there's not a requirement for a referring provider's NPI number on either of those claims at this time.
All right, thank you.
That goes the same with United.
Okay. Same with HealthFirst and Fidelis, I guess, or?
Correct.
Similar? Okay. Well.
Yeah.
Well, that makes it easy and pretty straightforward. So I appreciate that. Yvette, I know you've been monitoring the chatbot, so Yvette Kelly, our colleague from MCTAC as well. Anything that you have seen that kind of jumped out that you want to maybe
Yeah,
raise?
yep. So there's a couple questions that providers that have come in regarding just the submission of secondary and tertiary claims and whether or not they need to be submitted on paper with the primary EOB or whether or not they can be submitted electronically with the appropriate CRC codes. So maybe if the panelists can just speak to that, because we did have a couple questions come in regarding that.
So this is regarding rebilling, I assume, right?
Yes. Yep.
It sounds like, and I know, Elliot, I think you touched a little bit about the code 7 at the end, if I remember correctly, or at least I know that sometimes is not necessarily the question maybe that's being asked, but I know sometimes the denials that folks get, it's a duplicative claim, is sometimes related to that, what I refer to field 4, the famous field 4 in the paper claim at least, where you have to indicate if it's an initial claim or a rebill. But also there's other questions, so I'll leave it to the panelists. Cheryl, I think you wanted to jump in?
Sure, thanks, Boris. So I think there's two different things that are being talked about here. The secondary and tertiary claims is when there's a primary carrier, such as Medicare. So those would need to be, they can be submitted on paper with the Medicare primary payment EOB attached to the claim that you're submitting to Beacon. And that would be the same if it's a tertiary as well. You would need the primary, secondary payment submitted to us as the tertiary. As far as submitting it electronically, yes, you can do that. You just need to make sure that you set that up correctly with your clearinghouse, because you actually, I think you need certain permissions within the electronic submissions in order to submit those claims to us as secondary and tertiary. What you were just mentioning, Boris, was with the claim type ending in a 7, that would be for corrected claims. So if somebody is submitting a corrected claim, they would need to make sure that the bill type does end with a 7 and that they also have the original denied claim listed on that corrected claim so that there's something for the bill type ending in 7 to then refer to as an original claim.
Got it. Thank you for that.
You're welcome.
And that's the same for HealthFirst for correct.
Fidelis,
Go ahead.
Agree on the duplicate claims, corrected claims, that you are to put a 7 in to make sure. But if it comes to a coordination of benefit issue where you do have a primary insurance, Fidelis does not allow you to do that electronically. It would need to be pushed down to paper, and you would need to attach that EOB to it. And we do, again, highly recommend that you send it certified again so it's trackable.
Got it. Thank you.
So for HealthFirst, similarly with the corrected claims, you have to use the 7 and reference that original claim number. There's resources online on how to do that. With the coordination of benefits, I know this is very challenging for many providers. Ideally, you would do it on paper. If for whatever reason it's not working out, when you submit your appeal, just make sure you also attach everything in that appeal, and it would be handled through the appeal process as well.
Thank you.
So for United, you would, same thing with a corrected claim, you want to make sure you have that 7 at the end and reference the original claim number. And for the coordination of benefits claims, they can be submitted via paper or electronically.
Excellent. Thank you. I appreciate that. Yvette, again, just want to see if there's, I'm kind of scrolling through some of the questions as well.
Yep. So there's a couple of questions that came in just in relation to claim denial as it relates to location. So I think what some providers are saying, they're seeing a denial because of an unrecognized service location address. And so they're just looking for guidance regarding that.
Sure, I can take that. So if you're seeing a denial based on the location, you're going to want to make sure you reach out to your network manager to get that location added. And then once that location's added, it'll be added to your profile and claims will process based on that, having that added.
Got it.
Yeah, I would say the same for HealthFirst. If you are adding locations or closing locations, you need to make sure you update us on that activity to ensure that your profile is up to date. I don't think we would expect, at least on our side, denials for that reason. But especially if you're adding a new MPI, I think that would be key there. Again, if you experience that and your added locations, reach out so we can ensure that your profile is up to date.
Yeah, for Fidelis, I don't see how. You just have to make sure that you're putting the correct place of service down for representing what kind of provider you are. But if you ever need to add or remove an address, just let us know and we would do that for you.
And for Beacon, if you're getting a service location denial, that means that you have not submitted a service location addendum. We actually need to credential that site and make sure that you are licensed to render that service at that site. So you would want to just double check with your credentialing team. And for Beacon, you would simply need to contact our National Provider Service Line, and they would be able to assist you with which locations are actually currently credentialed and which you may need to submit a service location addendum for.
Excellent. Yeah, and thank you for that. Clearly, discussion around credentialing is important and very much relates to, as was pointed out, to some of the denials, and especially around adding a location in some instances. And I think as pointed out, especially if NPI is changed or added, so there's many reasons, which leads to the whole communication piece. So, as I'll keep repeating that and making sure that the plans are aware of your actions and where things are being provided and where they're not kind of being provided. There was a question if folks can, hopefully it could be a somewhat of a quick response, but there's a question about what's the difference between an administrative appeal or a denial related to medical necessity. So if anybody would like to kind of answer that one, or.
So medical necessity denial is done through the clinical team via the authorization process. Generally, there are a lot of rules around when medical necessity can be evaluated for various services, and of course, we would adhere to that. So for if for whatever reason you're receiving medical necessity, it shouldn't really happen with outpatient too much. I would find that really hard to believe. It would be a one-off. I couldn't think of a scenario right off the top of my head. I'm more on the inpatient side, and usually retrospectively, not
Prospectively.
So I would say that's what a medical necessity denial sort of means. A claims denial is something related to the actual claim submission, a reason why that claim did not pay, which may be related to not having an authorization on file, that clinical component, but is not always.
Got it. Thank you. Anything to add from other panelists, or that basically kind of covers it?
Elliot, it's very similar. Medical necessity denial appeal usually happens if your authorization is denied for not needing medical necessity. But the administrative appeal really happens when you get a denial for a claim, and you'd be approaching that differently. For medical necessity, you would be bringing documentation that's medical, clinical, while claims, really your rationale for what is underpayment or denial, and your rationale for that.
Yeah, and go ahead, Cheryl.
Sure. So also the same medical necessity denial is because there's an adverse determination, for a certain length of stay not being approved. Maybe some days were approved, but not all days. And the administrative denial would be where the provider, the facility, did not notify us at all that the patient was inpatient. And then in those cases, we would do a retro review. So we could, erase the administrative denial, but you could still then also have a medical necessity denial because on the retro review, we found that medical necessity was not met. So there could be both on the same stay.
Got it. All right. Heidi, anything on your end? Just want to make sure.
No, I think that my colleagues did cover it all.
Yep, thank you.
Thank you.
So I know since we're talking about different types of denial, I think, I just want to make sure to also mention that sometimes for providers, it gets a little bit confusing in terms. So there's kind of these official denials, right? You get notification from your plan that this was either medical necessity or administrative denial. But sometimes I know providers refer to a term denial where technically might have not been a denial, but more of either their own system or a clearinghouse held the claim back because maybe they have their own internal processes that kind of says, hey, it's not clean enough to go out the door. And so I always like to remind providers that they should be looking at those reports because it actually has never gone to the plan and it's not actually technically a denial because they haven't even had a chance to review it. And I think sometimes, and correct me if I'm wrong, the clearinghouses some of the plans use might also have, I think it's called maybe a rejection or some other term that it's not even technically might come in under a different category. And sometimes providers miss that because they're just looking for denials. So I don't know, do you guys have any insight into that in regards to, are there other responses that providers can get from you, or are they all, if they do get a response, it's either payment or denial? So just, I don't know if I stumped the panel.
This is not a game called Stump the Panel, but
That's right.
So if a claim is going in through EDI, through a clearinghouse, you can actually get a rejection. So it'll reject before it comes in our front door. And sometimes that will be because a billing NPI number or rendering NPI number is actually missing from the claim, or the member's ID number is missing from the claim. And that could potentially result in a rejection. And you would also get sort of a rejection letter that would tell you why the claim was rejected. Either there was a missing ID number, missing, NPI number, et cetera. So that would just be a reject before the front door. And then if the claim did have enough information, then you could potentially still get a denial for some other reason.
Got it. Thank you.
I wanted to add that there are also rejection reports with your clearinghouse sometimes that may be helpful when managing rejections.
Yep. Yeah, and I think that's where I wanted to confirm with you, with the panelists, because I know sometimes, because it's a different report than a denial report, depending on the setup and what comes through. And sometimes folks, rightfully so, focus a lot on denials, which they should, but don't focus enough on the rejection, right? Or miss it somehow, or somehow it's coming in through a different route. And so, I'm always just want to remind folks that there are different kind of statuses that come back, or the reasons why you haven't received payment yet, and to make sure they pay attention to both. Let me turn back to Yvette to see if there's anything else. I know we're getting a lot of questions, which is really great.
We had a couple questions come in earlier, and I know the panel spoke of this, but that we did have a couple questions just about the timely filing rules. And if the panelists can just spend a few moments to talk about that, because we did have a number of questions in terms of the days for timely filing.
Sure, I can take that quick. For United, it's 120 days on your initial submission before it would be denied timely filing.
For HealthFirst, it's
Yeah,
180 days. We did it again. Good.
Yeah, so for Fidelis, it's 90 days from the data service.
And then for HealthFirst, it's 180 days from the data service for timely filing.
And for Beacon, regardless of the number of days for timely filing, we want to be able to work with our providers. So if there's a reason, if you're having an issue, and we would certainly encourage you to contact us and let us know what that issue is. We can certainly go back to our plans and ask permission to waive timely filing. as a one-time, you know, thing to try to help you when you're having a specific issue. But, you know, anytime you have, you know, a batch of claims or, you know, several claims that are denying for timely filing, please reach out to us and try and let us know what's going on. We will certainly try to work with you in our plans to get that timely filing waived where we can.
Yeah, thank you for that, Cheryl. I wanted to just want to echo that, and I wanted to add that. So even though there are dates, right, and I think New York State rule is it has to be at least, plans have to offer at least 90 days, some offer more, like, you know, and so forth. But I think it is important, what kind of what Cheryl said is back to that. I know people are going to roll their eyes, even though I can't see it, you know, to communicate and talk to the plans about it. I know in our earlier this week panel, there were questions around COVID, and people were under the impression that timely filing was automatically extended to like a year or even more. And you know, and I know Heidi was actually at that panel. You know, we talked about that. It's not an automatic extension, but clearly during, you know, COVID, especially in the beginning stages, people had to scramble to figure out how to work from home, how to get their systems running differently, how to generate claims differently. That could have delayed all of that process. And I know all of the plans talked about, like, if you just reached out to us and you tell us, hey, I'm moving from this to that, or I'm implementing a new billing system, you know, I think what I found always that, you know, all the plans are flexible as long as you communicate with them, right? Rather coming back 6 months later, a year later saying, hey, I have 1,000 claims that denied due to timely filing, can you just pay them? Right? Versus coming up and saying, hey, I'm implementing a new billing system or a billing system, because maybe you didn't even have one, and saying, you know, I thought I'll get the claims out the door, but clearly I'm running into trouble. Can I work with you? And so I appreciate that, Cheryl, that you mentioned that. And, you know, I'm pretty sure I can speak on behalf of all the panelists around that communication piece. So I don't know if anybody wanted to add to that. Okay. All right. Yvette, other questions that are popping up?
Yep, so there's a question around telehealth and in-person visits being billed on the same UB04 claim. So someone's currently offering those services and wondering if those services can be billed on the same claim.
So I guess my answer would be, if they're billing them on this for the same date of service on the same exact claim form, you would need to make sure you're adding that telehealth modifier to the service that you're providing via telehealth, and leave that modifier off to the other service. But also make sure that they're a service that's using the same rate code, because for United, it's one rate code per claim.
Got it.
I would echo that.
Yeah, for that, it's the same thing. One rate code per claim is the most important thing. But what distinguishes the claim, the service is for telehealth and non-telehealth would be the modifier. So if you're dealing with the in-person, you would not include the telehealth modifier.
And from the Beacon standpoint, there could be a couple of different scenarios. So usually it wouldn't be usual to do a telehealth and an in-person visit on the same day, but I suppose you could do that. And then, of course, you would bill the correct telehealth modifier and the rate code if you're billing it on a UB04. But if you're doing a telehealth and a therapy, or a telehealth or an E&M code, et cetera, if you happen to be using the 99441, 99442, or 443, then you could not bill another therapy code on the same day. I don't think that code is allowed within a 7-day period of another appointment. So you just need to be careful and read the instructions for each of those codes that you're billing. And like for the example, the 99441, if you're billing that on a HICFA, Again, it doesn't require a rate code, and it also does not require a modifier because the description for the code is telephone only. So just be careful with the descriptions of the codes.
Got it. Thank you. I also just want to give an opportunity. I don't know if our panelists were able to see any of the chat questions in, and wanted to see if there were any particular ones you wanted to answer, so just wanted or address. If not, that's totally fine. But again, just wanted to have that opportunity. And in the meantime, while you guys are looking through that, want to see Yvette, if we have more. I'm scrolling through it. I mean, I think we bundled some of these together. Some of the questions that we're coming in as we're trying to answer as many as possible.
Yeah, I did try to bundle them and theme them as the questions came in, but I do have a specific question around eligibility in portals. It's a question that came in. They said that there's times where they're getting letter requesting payments recalled or overpaid because the eligibility has changed after the billing and payment has occurred. And so is there any thoughts around how they could best resolve those?
So it sounds like in this situation, the eligibility was probably retro-termed. So the member showed as active on the date of service, so services were paid, and then we found out later that maybe that member didn't have coverage. Unfortunately, there is going to be an overpayment request to recoup back on those services, but then the provider should submit to the proper plan where the member had coverage at the date of service.
Got it. And I guess that would be a good, because I think the follow-up to that is, but we're probably now outside of the billing limits, right? Because by the time all of this happens, you're outside even 180 days, most likely. And so I think, my advice always to the provider is make sure you communicate that with the plan. Because if you just submit a claim that's 9 months old, because you now realize you have to give money back and resubmit it, you will get just a denial. So this is where I think communication comes into play with in regards to resubmitting those claims. Others, anything to add to kind of that conversation? Okay, and I think in general, I know eligibility you guys mentioned is one of the top, denials that comes up. We hear that a lot. I again just want to remind folks there's, a number of ways to check eligibility, right? So there's e-PACES on the Medicaid side to check eligibility. There's also your portals. I think if not all of you, I think most of you have a way to check eligibility for your members as well. So even if a provider for some reason doesn't have access to e-PACES, they should be able to check with yours. And I think it's important to say, it's good to ask and obtain, especially when people are in person, the card, but it doesn't automatically mean the person is still eligible. So I think it's important to have that discussion as well. Let me turn to Yvette, see if there's any other questions.
Boris, I'm still looking through here just to see. There is a question regarding a denial code, and that code is the after hours code 99051. And so a provider is not understanding why they would get that code. Is that something you guys can provide any guidance on?
What was the denial? Denial?
It's an after hours code of 99051.
So that at least for HealthFirst, that CPT code is typically covered under APG. So if it's an APG provider, typically if there's a special scenario or situation that needs review, certainly, bring it up. And I believe that, Maurice, I think you're on, I don't think you can use a modifier with that code. I think that's a key there.
So Marie, right?
Yeah, what we've recently seen when billing that code is it's being billed for telehealth due to the COVID rules. But what we're seeing is providers are billing that code with a 95 modifier, and OMH guidance is calling for the GT modifier to be used with that code. So it's just important for providers, if you are billing for telehealth, to bill with the appropriate telehealth modifier for the codes that you're billing for.
Thank you for that.
Thank you. Yes, but I assume you can still bill after hours, right? So it's telehealth with modifier, and then still indicate if that telehealth, happens at 8 p.m. or Saturdays or Sundays and something like that, right?
Right. It's just the appropriate modifier needs to be appended.
Got it. Yes, it's back to that. It's not just the right general codes to use, but it's the combination that's also important. I think sometimes folks forget that or miss that well, 95 is a good code, or GT is a good code, or modifier, whatever it might be, and they put it in, but it's not good in a particular scenario or combination. So, and I know you talked about that, some folks talked about that as some of common denials. Others in regards to that after hours, anything to add?
For Beacon, the only time I see that denied is for non-Medicaid plans, where providers are telling us they're billing it when a member has Medicare as primary. And even though it's not covered for Medicare, they need the denial so that they can then submit that code to Medicaid for payment. But I don't usually see that denial on a Medicaid claim.
Got it. Yep. So, go ahead.
I don't really see this code denying frequently, but if there is an issue on the Fidelis end, I urge you to reach out to us so that we could review it specifically.
Okay. Sounds good. So there's also a question about, can I submit multiple dates of service on the same claim? I assume the answer is yes, as long as it's the same rate code, right? Because reminding folks, but just wanted to check if there's any other criteria or other things you guys want to add to that.
So for Beacon, yes, just make sure you're billing them on separate lines and not billing them as a date range.
Got it. Others, same thing, as long as it's the same rate code for the same individual.
Yes.
Okay. Let's see what other questions we have. And just, there are definitely interests in enrollment in different portals, and being able to, kind of in your initial presentation to talk about accessing information. And I assume if folks are having trouble either enrolling or working through some of those websites and portals, I think you have also contacts in that scenario on the slide that we will be sharing, or are there any individual people that specifically should be reached out to if I'm trying to kind of enroll and be able to access all this resources you guys talked about? So just wanted to check in regards to that particular contact.
Go ahead, Cheryl.
Sorry. So for Beacon, we do have our website that has a lot of information, and it's pretty much an open door into everywhere. And also our National Provider Service Line, which is also an open door into any questions that you have. They can route you to the correct areas.
Got it. Go ahead, Heidi.
Yeah, for United, I was going to say one of the sites that I provided on the slides, Provider Express, gives you a lot of information and can help navigate you through some of the situations you might have with enrolling. But if you're not able to find what you need out there, absolutely reach out to the network manager on those contact slides who is in your area, and they can help you.
And for HealthFirst, you would reach out to your account manager for assistance to direct you similarly.
Okay. And Elliot?
Yeah, for Fidelis, I provided a phone number that you can get to our provider call center. You can also reach to me directly, and I would set you up.
All right. I always tell people be cautious about telling them to contact you directly, but you're a brave man, Elliot. All right, but that's good. But it's also very helpful because then, people know, exactly who to reach out to in regards to this. Let me just see if there's anything else. Yvette, also please feel free to jump in, or any of our panelists again. If anything else has occurred to you that you wanted to add, or other things folks are seeing, I just want to make sure we have an opportunity to talk.
So this is Cheryl from Beacon. So one question that I'm seeing is, are you not charging client responsibility due to telehealth services? So this particular panel is regarding Medicaid.
Correct.
Typically, you would not have a copay or co-share cost share for a Medicaid member. But for other plans, yes, it is dependent on the plan, especially if they're an employer group, et cetera. But for the purposes of Medicaid, there's not usually a cost share, but if there were, that would be waived for telehealth.
Got it. Thank you.
Same for HealthFirst. There's no cost sharing typically with Medicaid. But for the public health emergency, we're obviously waiving the cost share, but it's not necessarily happening systemically. So it may be done through reprocessing in many instances. And so you may see the adjustment later.
Okay, thank you. Anybody else?
Yeah. Fidelis, I just wanted to point out, on our website at fideliscare.org, we actually have updates for COVID emergencies. So I would highly recommend for those questions to just take a look at that link for the updates, because it does provide you, the cost sharing information and the telehealth information, and even some billing guidelines. So I highly recommend you take a look at that as well.
Great. Thank you. There was a question about services on the same day. We actually have, I think, a couple of service questions about that. And just any general thoughts when providers, they might be providing medication management and psychotherapy on the same day. We talked about you can submit multiple dates on the same claim, so that's allowable. But are there anything else folks should be thinking about or concerned as it relates to billing when you do bill for two different services on the same day? Any general advice or thoughts?
So this is Cheryl again. So one of the things that I've come across a lot is providers billing two services on the same day on two different claim forms. And the reason that this happens is, it's required. You have to bill it on the same form when it's a UB and, the same rate code and everything. But when they're being billed on separate forms, it's because the member is seeing a physician for a 99213, for example, for an E&M code, and then going down the hallway and seeing a therapist for a 90834. Well, the therapist puts her notes in first, and they submit that claim. And then the doctor puts her notes in 2-3 days later, and then they submit that claim. So the first claim pays for the therapy code, and then the second claim denies because it needs to be billed on the same claim form as the first one. So now you have a conundrum where you have to kind of retract that first claim or submit a corrected claim, add both services to the new claim. Do you submit it as with a bill type 137? There's a lot of different scenarios going on because you've billed those two services on two different claim forms, when the 599 billing guidelines state you have to bill them on the same form. So I don't know what the answer is, and I would love to know what the answer is. Sometimes I've asked providers to, can you, if you know that the patient is having two services in one day, can you delay your claim submission until all of the notes are ready and both codes are ready to go out on the same claim form? So I know that is a huge issue for some of our providers. So I just wanted to put that out there, that when you're having those denials, technically they're provider billing errors. So if the providers can, come up with something internally to make sure that does not happen, that would be a huge help.
That's great. So I think one thing just to highlight is, what providers should be doing is putting those two services on the same claim. I think that's one message that I got from what you're saying, right? Clearly, there might be technical issues or more operational issues than technical for providers to do this, and you kind of highlighted a good example. But in the best case scenario, if there's two services on the same day go on the same claim, there should not be a problem in reimbursement. Okay, thank you.
Yes, that's correct.
Others, anything to add to that comment, or any other thoughts?
I think that you have to pay close attention to the billing guidelines you have. There are a lot of exceptions where services can't be billed on the same day, and you have to make sure that you're following those guidelines, and you know what you're billing and what would prevent you from billing another code on the same day. You really need to be following those procedures.
Excellent, thank you. And Cheryl, in your example, when somebody bills one, then bills the second one, gets denied, and then you have to do certain things. I call it, at that point, you have to do billing gymnastics to try to figure out how do you get backwards through many different moves, probably, to where it should be. Yes.
Yeah. It gets difficult because now you're trying, because a lot of times they bill the first one, and then both billers don't realize that the patient was seen by two different providers. So they don't bill it immediately. So they just bill the E&M code all by itself on another claim. So now you have two distinct claims that one was paid, one was denied. You've got to now figure out how to get them both on the same claim where one service was paid and might deny as a duplicate. So, it's a difficult situation at best. And, if anybody is having problems with that, with the two services in the same day, not being billed on the same claim form, certainly open up those lines of communication with us, and we will try to help you, kind of manipulate your way through it the best that we can.
Yeah, no, and I know from experience, some providers, this kind of goes back to the question how often I can bill. Actually, it creates other issues like cash flow potentially or others, but gone to weekly bills. So this way it gives, like you talked about, that time to maybe catch those, two services on the same day. But it has its own, downside to it, right, from the provider side. But yeah, so that's true. So we probably have maybe for one more quick question to answer. I don't know if any billing is quick, but maybe this one is as quick as possible. So I don't know if you, as a panelist, are aware, but in a fee-for-service billing, meaning directly to Medicaid, there are these, as providers know of them as delay codes, right? This is back to the timely submission. And Medicaid allows you to put a particular delay code that says, the reason I'm billing you late is, and they provide those codes, right? There's very specific codes. And as long as you put those codes in, Medicaid will then pay you if the claim is delayed, right? Meaning timely submission. And I guess the question is, is there any process, do you accept those codes, meaning what Medicaid offers, or do you have any code setup system, again, back to timely submission, to indicate to the plan the reason something is coming in late? Outside of what we already talked about, please communicate, discuss with with you folks, and let you know. Is there a technological approach or way to do that?
Hi, for HealthFirst, we don't accept those delay codes, unfortunately, and the claims would deny after, for us, it's 180 days from the date of service. If you're experiencing, sort of what you were saying earlier, back to your theme of communication, you're implementing a new system or you're having some sort of systemic issue, just reach out to us and let's communicate around that proactively rather than reactively.
Thank you. Cheryl?
Basically the same. We don't use any delay codes technologically, but if you would have used a delay code to submit to fee for service, then certainly, again, open up those lines of communication with us and we'll try to help you out.
Thank you.
I'd have to echo that myself. Communication is key in this situation. Let us know what happened, why you weren't able to get those claims timely, but we don't take those codes.
And Elliot?
Yeah, we don't take the codes, but I would say that if it's a one-time thing to appeal it, follow the proper appeal process. If you're looking at a high volume, in that case, you should get a provider relations rep on board.
Excellent. Well, I think with that, I just want to say again, thank you to all of our panelists for their presentation, their time, and the discussion. Really appreciated that, and all of our attendees who joined us today. So just want to say thank you and have a great rest of your day. Take care, everybody.
Thank you. Bye.
Thank you. Bye-bye.
Thank you. Bye-bye.